Welcome back to Endo in a Bite. Today is our part 3 of a 4-part series covering the Endocrine Society Guidelines 2025 on primary hyperaldosteronism. In part 2, we looked at factors that lower the ARR. Today we're covering the flip side, medications that raise the ARR and increase false positives. Let's start with centrally acting alpha-2 agonists. Now remember that centrally acting alpha-2 agonists bind to alpha-2 receptors in the brainstem, which are responsible for the autonomic control of blood pressure. These receptors are autoreceptors, and their activation inhibits the release of norepinephrine from presynaptic neurons. This in turn reduces the excitatory output to sympathetic preganglionic neurons in the spinal cord. So since norepinephrine is a major neurotransmitter in the sympathetic nervous system, reduced release leads to decreased sympathetic tone. Now, how does this affect our screening? Well, these drugs decrease the plasma aldosterone concentration, or PAC. The mechanism here is that these agents reduce sympathetic outflow from the central nervous system, since sympathetic activity enhances renin release. Reducing this activity indirectly lowers aldosterone secretion. The primary action is that the inhibition of central sympathetic outflow reduces beta-1 stimulation of the juxtaglomerular apparatus, suppressing renin release. Since the RAAS cascade is renin-dependent, a reduction in renin directly lowers aldosterone production. So, for centrally acting alpha-2 agonists, we see a decrease in renin, a decrease in plasma aldosterone concentration, and an increase in the ARR, which gives us an increased false positive rate and a decreased false negative rate. Next, let's consider beta blockers. The primary effect of beta blockers is to decrease both renin and plasma aldosterone concentration. The mechanism is that beta blockers inhibit beta-1 adrenergic receptors in the juxtaglomerular apparatus of the kidney, leading to reduced renin release. This reduced renin leads to lower angiotensin II, which in turn reduces aldosterone secretion. This leads to an increased ARR, giving us an increased false positive rate and a decreased false negative rate. Now let's move on to non-steroidal anti-inflammatory drugs. NSAIDs decrease the plasma aldosterone concentration. The mechanism here is that they inhibit cyclooxygenase enzymes, reducing prostaglandin synthesis. Prostaglandins normally stimulate juxtaglomerular cells in the kidney. In patients with conditions like primary aldosteronism testing, chronic NSAIDs use can reduce PRA and therefore falsely lower the ARR. Finally, let's talk about the effect of combined estrogen and progestin OCPs and HRT. This is a big one to remember. The combined hormones raise PRA and lower DRC. The explanation is that estrogen increases angiotensinogen production by the liver, which then increases PRA. However, estrogen may lower DRC, creating discordant results depending on which assay is used. Regarding aldosterone, these medications raise aldosterone levels. The mechanism is that the increase in PRA drives up aldosterone via the RAAS pathway. Furthermore, estrogen effects on hepatic synthesis of angiotensinogen amplify this effect. The clinical implication for primary aldosteronism screening is that combined estrogen-progestin OCPs and HRT can significantly confound our screening. Remember, these meds both raise aldosterone and alter PRA-DRC assays differently. Now, given these confounding factors, it's clear that we need to address medication management before testing. Let's discuss the different strategies for medication withdrawal. When we're talking about minimal medication withdrawal, the approach is as follows. We stop MRAs and ENaC inhibitors 4 weeks before testing. We also stop beta blockers and centrally acting alpha-2 agonists 2 weeks before testing. The ideal full medication withdrawal protocol is a bit more extensive. We stop mineralocorticoid receptor antagonists and epithelial sodium channel inhibitors and other diuretics 4 weeks prior to testing. Then 2 weeks before testing, we stop beta blockers, ACE inhibitors, ARBs, dihydropyridine CCBs, centrally acting alpha-2 agonists, and SGLT2 inhibitors. So in today's bite, we saw that medications like clonidine, methyldopa, beta blockers, NSAIDs, and combined estrogen-progestin therapy can all push the ARR higher than it really is, creating false positives and making screening for primary aldosteronism look misleading. That wraps up part 3. In our final episode, part 4, we'll move past ARR and into the next steps: suppression testing, adrenal vein sampling, recognizing cortisol co-secretion, and key treatment strategies for unilateral versus bilateral disease. For notes and weekly pearls, visit www.easyendoprep.com. Thanks for listening. And remember, stay consistent and keep it bite-sized.